It's good to see some familiar faces in the crowd. I joke, I think after this year, we're all probably going to have a PhD in Zoom when it's over with. Can everyone see my screen? We good? So again, I'm Steve Davis. I'm currently in the School of Public Health in the Department of Health Policy Management and Leadership. Prior to that, I spent about 19 years in the School of Medicine, the Department of Emergency Medicine. And part of what I did in emergency medicine, in addition to the research programs, was I lectured on evidence-based medicine. And so part of what I want to show you quickly this morning is a piece of that, because only having around 10 minutes to get into a discussion of how do you find really good evidence, or where do you even start, takes some time. But really searching for the best evidence, whether that be for to design a research question, maybe it's something based on your own clinical practice, it really starts with asking a focused question, because if you can ask an answerable question, then that can facilitate quickly finding information. Because rumor has it, you're pretty busy, and whether clinicians, researchers, all of the above, you don't have a lot of time. And so the beauty of of evidence-based medicine is it facilitates doing these things rapidly. And so one mnemonic that is recommended is the PICO method. I don't know if you've heard of that. If you haven't, though, it's basically framing your question, and we'll do an example here quickly, according to this mnemonic: patient population. The intervention could be a diagnostic test, a therapy, medication regimen, etc. The comparison intervention, which sometimes can be doing nothing, to be honest with you. It might be placebo, or it might just be doing nothing. And then your outcome of interest. And so let's get right into a concrete example. EBM, though, a lot of this comes from the bedside. That's the beauty of it. What your questions that might turn into a research question might come from your own patients, from your own practice. So let's do an example, which was an issue, still is an issue in emergency medicine for all the people coming into EDs with chest pains. They've got negative initial studies. What do you do? Because in America, we tend to admit a lot of them because we're worried about malpractice. But one of the things you look at is, okay, how good is that CTA? How good is it? So for patients presenting to the emergency department, they've got chest pain, they've got some negative initial studies. How accurate is their CTA, right, compared to actually admitting them and undergoing the serial troponins and other testing in terms of correctly detecting, whether they've got ACS, and looking at in terms of sensitivity, specificity, likelihood ratios, etc. So that can be from the bedside, real world question. First thing you want to do is get it into a focused question, asking an answerable question. Then from that, obviously, we want good evidence, or evidence that has scientific statistical merit and is clinically relevant. That gets into the so what question. Are the results big enough that you might actually change the way that you practice medicine? Or are they big enough that they would be compelling if they were a part of a grant application, as another example? We're familiar with the evidence pyramid. Obviously, we want to go from what we call the worst evidence. Across the board is expert opinion. That was actually one of the driving forces of evidence-based medicine, was going from doing things just because someone who was recognized as an expert said this is what we ought to do, to really getting to empirical results, and really across, whether or not you're talking about a therapy question, diagnosis, etc., across the board, systematic reviews, well done studies. This is what we consider the best evidence. But as I promised, how do we do this quickly? How do we do it quickly? And how we do it quickly, and what I believe is why we have evidence-based medicine, or evidence-based fill in the blank as a movement, is because we have the internet, and when we have these electronic repositories of good evidence. Now, we don't have time to talk about it today, but there's a whole nother part of evidence-based medicine that deals with, after you find evidence, can you critically appraise it to make sure, is it in fact good? But if you look in one of these places, this is going to maximize your probability that you're quickly finding evidence that is considered good. Now, I've left the links here in the interest of time. What we're going to do right now is just a very quick example based on the question we threw out using PubMed clinical queries. PubMed, most of us have access to, hopefully a lot of us are familiar with. I don't know if you are familiar with clinical queries or not, or if you've used it or not. I may actually have to just go ahead and open this up. I'll just go ahead and open up PubMed on a separate tab since it doesn't want me. 1 second. Doesn't want to let me open that up in my PowerPoint. And so essentially I've left the link there, but if you typed in this link or you went to PubMed in any internet browser, you get this screen, which some of you may be familiar with. But what you may not be familiar with, if you scroll down, is this clinical queries function. If you click on this clinical queries function, what this is doing behind the scenes, we're going to type in some search terms directly from our clinical question. But if you look at this filter information, what this is doing behind the scenes is it is automatically blowing in terms that are going to maximize the probability of returning articles that are higher up on the evidence pyramid, and thus saving you time when you're trying to find good evidence. And so that's the beauty of clinical queries that you may or may not know of in PubMed, as opposed to just doing PubMed directly. So if we look at, we're in clinical queries and we type in directly from our question, I'm just going to type this in. We were interested in chest pain. I'm going to use and. We were interested in specifically emergency department and CTA. Now we'll go down here and, if you're interested in COVID-19 articles, that's obviously very popular right now. You can do that. If we go over here, you want to make sure, because this is not a therapy question, that you change this to, this is a diagnosis question. And then you're going to see here that you've got 93 results, but importantly, that's because the scope is defaulted to broad. So you want to change this to start out with narrow. In changing these things, it's changing the behind the scenes filters that I showed you there to really come up with, okay, what did we really find here? And now you've got 17 results that hopefully, if you look through some of them, you can see down here right away, one of the things looks like it's something that very quickly might be of interest to me based on my actual question. Troponin, CTA, evaluation of suspected ACS in the emergency department. And then you could go on to the critical appraisal. But the other thing I want to show you, in the interest of time, because I know it didn't have a lot of time, is you can also actually put the word review into the term. And so if you do that, you get really focused. Now we're down to 5 results, and you can see here that right away we've got meta-analysis and systematic review, which is the highest level of evidence, CTA, in the emergency department for chest pain. So that's a very quick, just running through it. I think I'm around 10 minutes, maybe a little over, but that's what I wanted to show you this morning. Obviously, you are free to reach out to me. I certainly will take questions as well, but I have left my email there. I know some of you as well. I also, Tracy, could send you this PowerPoint if you like. I think you have this PowerPoint. I've left you some really good hyperlinks to evidence-based medicine that go through all of this and more. Not just asking answerable questions, searching for the evidence, but also critically appraising the evidence. And then you can even take it to applying the evidence to the bedside. So if I'm over time, I tried, but
no, you're great.
Tried to keep
that
on
was
there.
Great. Thank you so much, Dr. Davis. That was.
Oh, it's a pleasure to be able to come and talk.
Yeah. Does anyone have any questions for him?
And if you do, please reach out to me. I know many of you, it's good to see everybody in these times, even if it's via Zoom. Whatever I can do to help, just let me know.